Thank you, everybody, for coming today. I know we'll get quite a few more people as we got the minutes click off here, but we want to get started because Dr. Systrom has a lot to say. So today we're really privileged to have Dr. David Systrom, who's a member of the Brigham and Women's Hospital's Pulmonary and Critical Care faculty at Harvard Medical School, where he directs the dyspnea clinic and the advanced cardiopulmonary exercise testing program. He's been on the Harvard faculty for 35 years now, and he's received grant support from everybody, NIH, DOD, private foundations. Currently, he's got a study underway with OMF that he might get to talk a little bit about today, I hope. So over the past 5 years, he has been using invasive cardiopulmonary exercise testing to investigate mechanisms for that underlie fatigue, shortness of breath, and orthostatic intolerance in MECFS and in PASC or Long COVID. His recent work suggests commonality between the two, in particular, the neurovascular dysregulation and related hyperventilation and underlying symptoms during exercise. He's the PI of an ongoing $8 million study on limb skeletal muscle mitochondrial dysfunction, and has just completed the first ever randomized clinical trial of pyridostigmine in MECFS. So with no further ado with all that, I'm going to introduce my friend David, who's been so kind to say he would talk to us today. So welcome, David. Thank you.
Thank you so much, Nancy, for the kind introduction, and it's great to reconnect with you and your group. And my hat's off to everything you're doing down there in South Florida. Some phenomenal stuff, which I am aware of, and Nancy and I have had discussions about. As Nancy suggested, I was going to cover, it'll be a little less than an hour and plenty of time for Q&A, some evolving notions about the pathophysiology underlying exercise, acute exercise intolerance in MECFS and Long COVID. And as Nancy just suggested, there are, we think, a huge amount of commonalities between the two disorders. And in many respects, they may be identical. I have one disclosure, Nancy, which I just shared with your team, and that is I have 2 golden retrievers here at home, and their dog walker is going to come, and I guarantee you there will be a little noise for about 30 seconds. So I may have to pause just very briefly to get them out the door. Apologies for that. And I do have a picture of them at the end here. So in any case, let me tell you a little bit about how we got into this business. And here's a table of contents about what I'd like to cover. Our major modality, not the only one, not the only biomarker, but our major insight into these diseases, and by that, of course, I mean both ME and Long COVID and acute exercise intolerance, is the invasive cardiopulmonary exercise test. And I will likely fall back to the term CPET, the acronym, repeatedly, just because it's near and dear to us. And as Nancy suggested, we've been using this tool for many, many years. Originally, it was developed at Mass General in an effort to detect early heart disease, early pulmonary vascular disease, and to a degree to differentiate between heart and lung disease. And as I tell you this story, I hope you'll understand how we got into the business, which was we identified a cadre of patients who ended up having ME and then Long COVID without any heart or lung disease. And it was kind of a distinct pathophysiology, which I will cover here. So then I will try to build a case that at least part of the exercise pathophysiology is neurovascular dysregulation in origin. It may not be exclusively that. There are other bona fide theories. They're not all mutually exclusive, but I'll make a case for at least a component of this in a subset of patients. I will then turn to 2 drugs, and as Nancy again just suggested, I will come to this trial that is OMF, Open Medicine Foundation funded, called the LIFT trial, that we've, after a year of jumping through regulatory hoops, have launched and are now on patient number 3 of 160 at the Brigham in Boston. So I will build a case for pyridostigmine and its usefulness in this disease, aka mestinon. I will briefly turn to low-dose naltrexone, which I'm sure the clinicians are familiar with. I am going to tell you a little bit about a retrospective study we call Baby Lift. It anticipates the prospective randomized clinical trial called Lift. So in order, we'll do all of these things, I hope. A little nod for a second to our predecessors. There was this interesting place back in the day at the medical school, and even more particularly at the Harvard Business School in the basement, curiously, where the dean of the business school and the dean of the medical school got together, decided they were going to make the workers of the world more productive, and correctly deduced that if they understood fitness and training, exercise training, they could have more productive workforce. So they created this first ever human exercise physiology lab in the basement of the business school. And this is a picture of one of the early subjects. Many of the basic tenets of exercise physiology, they actually put on the map and have remained true to this day. Here's the basement of the Brigham and Women's Hospital these days, and I'll just show you for a second a little bit of what we do here. This is a gentleman who agreed to be filmed. He had exercise intolerance, as most of our folks do, almost all of them. Many in the audience, I think, are familiar with the non-invasive cardiopulmonary exercise test, which is largely shown here. He's got a pneumotachograph in his mouth, which measures minute ventilation, and then he's got measurements of expired and inspired pulmonary gas exchange. So that's the non-invasive portion hooked up to a MedGraphics metabolic cart. The invasive part of the test are constituted by two catheters. One is a radial artery catheter shown here in his left wrist, and another is a pulmonary artery catheter put in by one of my interventional colleagues, Dr. Waxman, around the corner from the exercise lab before the test. From those things, we get a whole bunch of data. And I will say, with respect to ME and long COVID, without these catheters, we're really groping in the dark. It's hard to know what's going on in the interior of the organism. So here are some of the things that we measure. These are the non-invasive variables measured at the mouthpiece. The O2 uptake, it's a timed variable, the CO2 output, and the minute ventilation, as I mentioned a second ago. From the radial artery catheter, we get systemic blood pressures, not shown here second to second, but we also get arterial oxygen content, and you'll see why that's important in a little bit to the diseases we're talking about today. We also get mixed venous oxygen content. That's one way to measure the ability of the periphery, in particular the exercising muscle, to take up and use oxygen during exercise. The more one extracts, the better. And then we've got pressures. We've got filling pressures on both sides of the heart, the right atrial pressure, and a surrogate for the left atrial pressure, which is called the pulmonary capillary wedge pressure. So we can measure filling, the ability to stoke the pump, as it were, on both sides of the heart, and you'll see why that's important in these diseases in a second. This is right ventricular pressures, largely germane to pulmonary hypertension, and then the pulmonary artery pressures, the input pressures into the pulmonary circulation. So from all these things, we're able to get a phenomenal amount of data, really either millisecond to millisecond, or in the case of some of these things like the wedge pressure and the blood draws every minute during incremental cycling exercise to exhaustion. Just for those of you who are curious, these tests take 5 to 6 minutes for a patient to reach their maximum. They, in general, do not precipitate PEM, or post-exertional malaise, because the intense portion of the exercise test is very brief. I will also say we've got lots of safety bells and whistles. We are measuring the systemic blood pressure. We can see somebody with orthostatic intolerance. These would be mostly recovery from exercise phenomena where blood pressure might go down a bit, they might get lightheaded. We can see these things coming, so there's a safety aspect to all of this. And the final one, for those of you who are recoiling in horror at the thought of catheters in wrist and neck, and then pedaling away, we've done formal surveys of patients having done this test. We ask them all at the end of the test who's worse, us or the dentist who does drilling, and 99% says the dentist, no offense to any dentists out there. So here are some of the things that we can get at from our testing. Up at the top, I hope you can see, is the VO2 peak. That's a measure of overall aerobic function, time-honored. It's expressed as a percent predicted. There's some other things that are not germane to ME or long COVID. The exception with long COVID is somebody who might have had really bad lung disease, ended up on a ventilator with interstitial disease. They might have a pulmonary mechanical limit, but I won't be talking about those patients today. Same answer for the patient with long COVID who might have had a cardiomyopathy. We could deduce that they have a left heart problem by determining that the cardiac output is down, the VO2 peak is down, and the filling pressures on the left side of the heart are up. I will not be talking about that small subset of patients here today. Then finally, there's pulmonary hypertension and right heart disease where the VO2 peak is down, the cardiac output is down, and there are high pressures, the input pressures into the lung circulation. That is exceedingly rare in long COVID. Doesn't exist really unless there are other diseases in ME, so I won't be talking about those. Where we will be ending up, and I'll build a case for this, is here, something we call preload failure, and out here, a peripheral limitation, which is manifested by an inability to depress normally the mixed venous oxygen saturation or content during exercise. And here's the differential diagnosis that I'll spend some time on. All right. So how did we get into this business, and how can I deduce, at least tentatively, that we have at least an element of neurovascular dysregulation? What does this mean in ME and long COVID? So I'll build a little story here. We got into this business back in the day. I think the bio says 5 years. It's out of date. You can do the math here. So we are now roughly 8 years out into this. What we were recognizing over time is that as lung docs, card-carrying pulmonologists, we had probably a disproportionate referral pattern for shortness of breath or dyspnea. But then we learned that most of these patients we were seeing who had unexplained exertional intolerance of all kinds, including fatigue and PEM, as it turned out, and orthostatic intolerance, who did not have any bona fide heart or lung disease, had something else. And that something else I'll describe here. Will Oldham was the first author in our first foray into this 8 years ago. So what we determined was that there was a subset of patients with something we have now called preload failure. It was really the only, at the time, the only identifiable abnormality during incremental exercise. And it was identifiable only in the upright position where gravity is the enemy. And it was only really reliably identifiable at peak exercise, not in the resting state. Little hint in the resting state. So what we did here was looked at our invasive cardiopulmonary exercise database. Was about 600 patients at the time. We weeded out, took out all the patients with true heart and lung disease. And then we were left with a cadre of patients who didn't have any heart or lung disease, but were complaining of exertional intolerance and had a depressed VO2 max, or maximum oxygen uptake at peak exercise. And we compared them to about 66 normal individuals shown here. And what identified these folks were low filling pressures, both on the right side of the heart, the right atrial pressure, again, upright and at peak exercise, and the surrogate for the left atrial pressure, the pulmonary capillary wedge pressure over on the left side. So preload failure is what we call this. It was failure to prime the pump against gravity. A lot of overlap, as it turned out, with POTS and orthostatic intolerance. We attempted to regress some time-honored variables related to classic exercise physiology, the VO2 max and the cardiac output at maximum exercise, against these filling pressures. And what you can see is there was not a perfect, but a loose association. The lower the filling pressure, the lower the aerobic capacity, the lower the filling pressure upright at peak exercise, the lower the cardiac output. And by the Fick principle, this was driving most of the low VO2 peak. We had an interventional cohort where we actually took a subset of patients and tanked them up after their first spin on the exercise cycle with the exercise with a catheter still in place. So about 45 minutes after their first exercise bout, if they had preload failure identified, they received normal saline boluses in an attempt to get the right atrial pressure up at rest, and then they pedaled again. And what one can see is that despite the fact this is a second exercise bout, the VO2 peak was higher, and the way it was higher was the cardiac output was higher, in turn related to stroke volume being higher after fluid challenge. And the way the stroke volume was better was increased filling pressures on both sides. One gentleman had a little precipitation of mitral regurg, he went downward. So this began to build a case, we think, for something we have called preload failure. And as I said briefly a second ago, we learned in retrospect, the hard way, that most of these folks met the current, back then, IOM criteria for MECFS. So this is where they landed in our exercise algorithm. And the VO2 peak was down, as I mentioned. It was down because of the cardiac output. And the root cause was not intrinsic left or right heart disease. There was no intrinsic lung disease. What they had was this failure to prime the pump. And this is our lower limit of normal for the right atrial pressure at peak exercise during upright cycling exercise, 6.5 millimeters of mercury. So we took a little deeper dive into this a couple of summers ago with the help of Philip Joseph, who's now at Yale. And we did a similar approach with an expanded invasive cardiopulmonary exercise testing database, in this case, over 1,500 patients. We did the same thing. We ruled out patients with intrinsic heart or lung disease and limits due to those things. We focused on those with the preload failure and additionally asked the question, how many met classic criteria for MECFS? And then one additional question in this paper was, how many of these patients with a single epidermal skin biopsy met criteria, such as they were then, for something called small fiber neuropathy? So I'll walk you through that. We designed this study a priori to mimic something that's been done in upright tilt table tests in POTS, which is to look for low flow states and high flow states. And the way we did this was to look at the slope of the cardiac output versus the VO2 during incremental cycling. This is a low flow group in blue. This is a high flow group in red that I'm going to focus on. And then by definition, we did tertiles. There was a middle group that had what's essentially normal in terms of the cardiac output versus the VO2, which is known to be about 5 to 6 ml of cardiac output versus ml of VO2. So I'm going to emphasize this because this was the novel finding. And again, this has been described by Dr. Raj et al. And upright tilt table tests in a subset of patients with POTS during an upright tilt table test. So the hallmark of this group is, by definition, a lot of pulmonary blood flow. This is what we measure by the Fick principle during our invasive exercise test. We measure cardiac output by measuring VO2 at the mouth, of course, and then the difference between arterial and mixed venous O2 content every minute and then at peak exercise. That's how we calculate this. So this is pulmonary blood flow. This is a lot of pulmonary blood flow, but their VO2 peak is decreased. And it's decreased because there's impaired oxygen extraction, failure to depress the mixed venous O2 content. You can express that in a number of different ways, but this is one of them, normalized for the hemoglobin. So this is a distinct subset of patients with a lot of pulmonary blood flow and impaired oxygen extraction by the muscle at peak exercise. This is the hallmark in the cardiology world of left to right shunting. And in the CARDS world, this is usually a septal defect in ASD in adults, atrial septal defect. We've got shunting of mixed venous blood going around and around in the pulmonary circuit and an effective O2 extraction in the periphery. But we know none of our patients have a hole in their heart. They've all had echoes, Doppler, and otherwise they've had step-ups of their oxygen saturations during a right heart catheterization, and there is no hole in the heart. Some of them have had cardiac MRIs. So this suggested to us that this is peripheral left to right shunting and impaired oxygen extraction. The additional question that we asked in this study was what was the prevalence of small fiber neuropathy? Initially, we were learning anecdotally and then systematically that many of the patients with MECFS, many who had documented POTS on a tilt table test or fibromyalgia clinically had a small fiber neuropathy, which is defined by a decrease in the neurite density. A definite diagnosis is less than the 5th centile compared to normal, and a probable is less than the 15th. And if you tally all these up, it's almost 45% of the patients with a single epidermal skin biopsy above the ankle had evidence of either definite or probable small fiber neuropathy. So for those of you who aren't familiar with that entity, we've known forever that the small fiber nerves mediate nociception, they mediate pain. But what's been increasingly recognized is they also have an autonomic function. And amongst other things, the small fiber nerves regulate blood vessel tone and therefore blood flow. So this was interesting to us. This prevalence was about the same as that described in fibromyalgia and POTS. More recent data, these have been presented at our American Thoracic Society last year, suggests sex predilection for this high flow, poor extraction phenotype. There is no difference in the preload failure or the VO2 peak according to sex. About the same for VO2 peak as a percent predicted and the peak right atrial pressures. But we have found a significant difference, a female predilection for this high flow state as defined in the Philip Joseph paper and either as a slope or as a percent predicted. So it appears females have more of this high flow, poor extraction phenotype, and we're actively investigating the influence of sex hormones on systemic vascular tone and therefore oxygen delivery to the exercising muscle mitochondrion. Right, I'm going to briefly turn to long COVID, but I will summarize up front by saying in our world, it looks exactly the same as MECFS. This was a small study in 2021, and we've since had a larger study I won't show you, and we have evolving data I'll mention briefly in a second. This is 10 patients with long COVID, at least 6 months out from the acute disease, free of heart or lung disease. And here they are at peak exercise compared to 10 normal controls. You can see that the peak exercise VO2 is depressed, modestly so. This is pretty typical of long COVID and ME. And the mechanism by which that VO2 peak is decreased is largely systemic oxygen extraction, here expressed in a slightly different way. But what you can see is it's about half normal at peak exercise. So this is that high flow phenotype with poor systemic O2 extraction. Small numbers, so probably a type 2 error here. There is additionally that preload failure in long COVID. So looks essentially the same as what we were seeing in ME. So this is where folks land largely with ME, CFS, and long COVID. There can be a dual whammy. This is ubiquitous. Preload failure is there in all but the most obese patients. We haven't published that yet, but preload failure is essentially in every patient we see with ME or long COVID at peak exercise. And then there's a subset of patients with an additional hit to oxygen extraction in the periphery. This is an arterial phenomenon. I think one can envision lax blood vessels, failure to venoconstrict here, and perhaps failure of the arteriolar resistors to redirect cardiac output appropriately to the exercising muscle over here on the arterial side. A brief touchdown on some notions put forward by a collaborator, Frank Rice, at Albany. He's done some skin biopsies of the hypothenar eminence, so that's the palm of the hand over to the lateral side away from the thumb, where he captures both the epidermis, which we were capturing with a small fiber neuropathy study, but additionally blood vessels. And what's exceedingly interesting to us, and this is one purported mechanism, is that we're all endowed with potential AV shunts, arterial venous shunts. And they are regulated by these small fiber nerves that secrete, amongst other things, calcitonin gene-related peptide, CGRP, which is a vasodilator. CGRP is known to be the major biochemical pathway for migraines, and as many of you know, many of these folks with ME and long COVID have migraines. Additionally, I asked a clinic question, it's a cheap one. If you're in the hot shower, do you get lightheaded and do your feet turn purple? And there's a phenomenally positive answer of yes. And I think what might be going on is this phenomenon where we are shunting blood from the artery to the vein, and we get hyperemia. And this is one of the organ systems that doesn't necessarily need a lot of blood flow at peak exercise, at least the incremental variety that we see. This is a steal phenomenon, as it were, and perhaps part of the peripheral left to right shunting that I'm suggesting here. So this would be neurovascular. All right, going to briefly turn to one of the drugs we've had a lot of luck with in the clinic, which is pyridostigmine or mestinon. This is an FDA-approved drug for myasthenia gravis, which most of our patients don't have. So it's an off-label comment here. Pyridostigmine's been used forever in the POTS literature, and that's where we got it from, where we borrowed it from. I'm going to use a little story about pyridostigmine and the randomized clinical trial Nancy mentioned at the beginning to build a case both for neurovascular dysregulation, but to also offer up a potential treatment, and then we will shift into treatment here with this and low-dose naltrexone and the two LIFT studies. So pyridostigmine. We published this 2 years ago in one of our cardiopulmonary journals, Chest. This was a properly done randomized placebo-controlled study of a single dose of pyridostigmine, 60 milligrams by mouth. And I'd hasten to add that in the clinic, most of our patients who notice mitigation of symptoms, exercise symptoms, orthostatic intolerance and fatigue and others, even PEM, with pyridostigmine do so over weeks to months, not a single dose. So this is really a proof of concept study. What we did was in a very similar fashion to the Oldham study where we did IV fluids. In preload failure, we had these patients do the clinically indicated invasive CPET first. If they had preload failure, they received either the single dose of pyridostigmine, 60 milligrams, or placebo, and then they pedaled again roughly 45 minutes later with the existing lines in place. So this is what happened. If they received drug, their VO2 peak actually went up compared to the prior baseline test shown here in green. If they didn't receive drug, they received placebo, it actually got a little worse. We wonder if this is the beginning perhaps of post-exertional malaise, very early, precipitated by the prior exercise. The mechanism by which VO2 peak went up in this RCT was increased cardiac output, shown here, compared to the prior baseline. Again, worse if they received placebo. And the mechanism by which the cardiac output went up was increased filling pressures, right atrial pressures in this case shown here, which were better compared to the prior baseline, worse if they received placebo. So pyridostigmine is thought to act during exercise and POTS and orthostatic intolerance, largely by augmenting this cholinergic step in the sympathetic ganglion. So pyridostigmine is known to retard the breakdown of acetylcholine in the neural synapse. And the way we think it works in these disorders is at the sympathetic ganglion, whose efferent neuron is sympathetic and, amongst other things, regulates blood vessel tone. So we think mestinon or pyridostigmine helps here, in turn helps somewhat paradoxically an adrenergic step and perhaps blood vessel tone, which is what we measured. I will readily admit the effect size was small with that single dose, but I think it's proof of concept that this is what patients might be noticing in the clinic. All right, so I'm going to give you an interim conclusion here, which is really the topic for today, is that both in ME and long COVID, we're exploring more of this as time goes on, there's evidence of systemic vascular dysregulation. On the venous side, there's failure to prime the pump. On the arterial side, especially in women, there's evidence of peripheral left to right shunting. So oxygenated blood is not getting properly to the exercising muscle mitochondrion. And then based on our skin biopsy data and the high prevalence of small fiber neuropathy, we tentatively conclude that this is neurovascular in origin. There are other theories about all this, including endotheliitis and microclots and other things, perhaps for another day. But at least an element of this we think is neurovascular in origin. And then I think the data from the randomized clinical trial with a neurally active agent, pyridostigmine, which to my knowledge doesn't fix microclots or endotheliitis, at least with a single dose, suggests that this is all neurovascular dysregulation, or at least an element of it is. All right, so I'm going to briefly turn to the other drug that we will be studying prospectively in the LIFT trial and retrospectively in what we're calling tongue-in-cheek baby lift. And that's low-dose naltrexone. Many in the audience, especially the clinicians, may know we've had some luck with this in ME and long COVID. So to briefly review, it's a mu opioid receptor antagonist. It's FDA approved, again, another off-label comment here, for alcohol and opioid use disorders, but it's used at 10 times the dose for those things that we're using. We've learned largely from the Finns and other Scandinavians that super low dose can be useful here and largely free of side effects. In ME, we know from a variety of centers, including the Griffith in Australia, it returns or restores natural killer cell function. So, and additionally, and I will put these two together, it's anti-inflammatory. So one of the major pathways is that low-dose naltrexone will tamp down the toll-like receptor number 4, which in turn downregulates the downstream NF-kappa B and the production of pro-inflammatory cytokines. It's unique and to a degree in the sense that it's anti-inflammatory while it's actually augmenting innate immunity rather than suppressing immunity and putting patients at risk for infection. So attractive from that standpoint. There's precious little data out there on its use in fibromyalgia-related disorders in ME. There is one study from a couple of years ago where there was subjective improvement in 115 patients with fibromyalgia and their pain. And then there was a retrospective chart review from Finland with 200 plus patients where self-reported responses were favorable. All right, so with everything that I've told you so far, building a case that we have an element perhaps of neurovascular dysregulation, we've come up with these two studies. The first is retrospective and with all the potential pitfalls of a retrospective study, but I'll show you a bit of data. And then the prospective one, which is ongoing, called LIFT. So baby lift is the retrospective one. What we're using here is a physiologic outcome called the SHAPE study. This is a cousin of medical graphics. It's a 3-minute step test. Even patients with orthostatic intolerance do quite well. They're able to hold on to this bar, stabilize. They go up and down. I'll show you in a second. For 3 minutes only. And we've got a metabolic chart that gives you many of the non-invasive variables that we get with that invasive CPET. These are actually two of our exercise physiologists showing us how this is done. Quite well tolerated, does not precipitate post-exertional malaise. 3 minutes, a lot of non-invasive data, amongst which is heart rate recovery. And that's what I want to show you here. This is our major finding in the baby lift study. So what we've got is a small number of patients, 11, treated with low-dose naltrexone alone. These are all MECFS patients. And then a larger number treated with pyridostigmine. This reflects how we got into the business. We did this first and more recently have added this. And then the combination of the two. And what you can see is a heart rate recovery after the 3 minutes of stepping over here. This is one of the major mechanisms by which we measure aerobic fitness. The faster one's heart rate recovers after exercise, the better, more parasympathetic tone. And what one can see is with pyridostigmine, there's improvement at 1 year of treatment of Mestinon and or with the combination of the two drugs. We didn't see much of a signal here, but again, potential type 2 error here. Then we had a cadre of patients who actually didn't get either of these drugs. They were all healthier to begin with, so it's probably a terrible comparator here. They didn't change much over time. They got no drugs at all. All right, so this is the last thing, and Nancy asked me to address this. The LIFT trial, it's the Life Improvement Trial. I didn't come up with the name, but this is comparing Mestinon pyridostigmine to low-dose naltrexone, to the combination, to placebo over 3 months with a variety of outcomes. And a special nod to two of our research coordinators, Johanna Squires, PhD, and Shreya Pelwai, who is applying to medical school, and we hope we'll hear something favorable very soon. These two folks have been instrumental in getting us through all the regulatory hurdles for this pretty large single study, a single site study. So it's a randomized placebo-controlled study. We're targeting 160 patients with ME. We're recruiting patients from my clinic and Donna Felsenstein's at Mass General. The treatment period is 3 months. And as I said a second ago, it's the combination of pyridostigmine and LDN versus monotherapy of pyridostigmine versus monotherapy of LDN versus placebo. And we've got a variety of outcomes that I'll show you. Initial screening, we're going to make certain they meet Canadian consensus criteria for ME. It's the age range. We are ruling out folks for the moment anyway with long COVID. So we're targeting folks with symptoms that began before the pandemic. We are attempting to get treatment naive patients, and they have to have a smartphone, and then some exclusion criteria. And then the ultimate goal is to get them up to a proper dose of Mestinon, which is 60 milligrams 3 times a day, escalating doses and the ability to decrease if we have to. And then low-dose naltrexone, which eventually will be 4.5 milligrams per day after initial run-in period. Here are some of the outcomes. One is a wearable device. This was the best one we found in the market. It's a Garmin Vivo Smart. Here are many of the things it is purported to measure. The patients will wear this for the entire 3 months. We've got a phenomenal computational group I'll thank at the end here, who have really automated the downloading of all these data and questionnaires that I'll show you here in a second. At day 0 and at the end of the study, patients will undergo these well-validated questionnaires, which many of you, I'm sure, are familiar with: FunCap 55, Promise 29, DePaul PEM, and Brain Vital. We are going to do that shape test that I showed you with respect to the baby lift study at the beginning, at the end. So we have physiology in addition to the questionnaires, and then we have a bunch of omics. So off to SomaLogic, we'll go proteomics, off to Elaine Moreau up in Montreal, metabolomics and transcriptomics, and then over to Cornell will be peripheral blood mononuclear cells for a variety of outcomes. I should say this is a total of $2 million funded by OMF, and special thanks to them. We're going to repeat these questionnaires and download them every 2 weeks during the study. So that's all I have to tell you. I hope to have made a case that at least for a subset of patients with both ME and long COVID, we have elements of neurovascular dysregulation, pretty ubiquitous on the venous side, failure to prime the pump, preload failure, and then additionally, especially in women, this impaired oxygen extraction and the high flow phenotype. The small fiber neuropathy data we have actually augmented. This is really late breaking news. I don't even have a slide for it yet. But we've got over 400 patients with ME and approaching 100 patients with long COVID. And when we do dual skin biopsies, one above the ankle and one up by the hip in an effort to get sweat glands, the sweat gland small fiber innervation, therefore the autonomic fibers, the prevalence of small fiber neuropathy in these two disorders approaches 2/3. So phenomenally high. So neurovascular dysregulation. I've already thanked Johanna and Schreier. This is our computational group. They're phenomenal, based at Mass General Brigham, Wenzong leading the charge, Peng and Joshua, Maureen Hansen at Cornell, Jonas in Sweden, overlooking everything, Alain up in Montreal, Ron Davis at Stanford, and then we've got our OMF folks, Linda Tannenbaum, who makes this all possible with the funding, and Danielle Meadows, a phenomenal PhD recent add-on who's helping us out. So I thank you all for your attention, and we'll see if there are any questions. These are the hounds who might be making some noise very soon here.